My name is Kelly Good, and I am the immediate past president of the Virginia Pharmacists Association. The purpose of the association includes assuring the viability and vitality of the profession of pharmacy in order to maximize contributions of the profession to public health and patient care. On behalf of the association, it has been an honor to partner with the VHHA, the Medical Society of Virginia, and the Virginia Nurses Association to host this year's Virginia Patient Safety Summit. It is now my pleasure to introduce our first keynote speaker. Dr. Arjun Srinivasan is the Associate Director for the Healthcare Associated Infection Prevention Programs in the Division of Healthcare Quality Promotion at the Centers for Disease Control, or CDC, National Center for Emerging and Zoonotic Infectious Diseases. He is board certified in infectious diseases. Before joining the CDC, he was an assistant professor of medicine in the infectious disease division at the Johns Hopkins School of Medicine, where he was the founding director of the Johns Hopkins Antibiotic Management Program and the associate hospital epidemiologist. His research and investigative areas of concentration include outbreak investigations, infection control, multi-drug resistant gram-negative pathogens, and antimicrobial use. From 2006 to 2010, he led the CDC's Healthcare Outbreak Investigations team. In 2008, he assumed the medical directorship of a new CDC campaign called Get Smart for Healthcare, which is designed to improve the use of antimicrobials in inpatient healthcare facilities. Dr. Srinivasan also currently serves as the deputy lead for the Healthcare Resiliency Working Group of the COVID-19 Federal Joint Coordinating Center. A graduate of the Vanderbilt University School of Medicine, Dr. Srinivasan is a member of Alpha Omega Alpha Medical Honor Society. He completed internal medicine residency and infectious disease fellowship at Johns Hopkins University Hospital. Dr. Srinivasan is an adjunct assistant professor of medicine at Emory University Medical Center and sees patients at the Atlanta Veterans Affairs Medical Center. This morning, Dr. Srinivasan will provide us with a report on the state of patient safety in America from the CDC's perspective and through the lens of COVID-19. Dr. Srinivasan spoke at a previous Virginia Patient Safety Summit and was well received. So we invited him to join us again. So please join me in welcoming him back to Virginia. Dr. Srinivasan.
Kelly, thank you so much. And thank you to all of you for this generous invitation. I am sorry that we can't be together in person. I really enjoyed being with you several years ago and getting to meet and talk with so many of you. So I will hope that this talk will also be well received, and maybe you'll have me back again so we can meet in person once again. And I just want to begin by reiterating my thanks to all of you who have been working on the front lines, caring for patients day in and day out through all of the challenges and complexities of the COVID pandemic, and recognize with deep humility that you do so at some degree of risk to yourselves. And so to thank you and to thank your families for all of the sacrifices that you and they have had to make throughout the pandemic. I know we're not done yet, so this is ongoing thanks. But it is with deep sincerity that we recognize the incredible work that all of you do to take care of patients. And thank you so much for taking a little bit of time out today to talk about how to keep people safe while we are delivering that high quality care. I don't have any disclosures, and I'm mostly going to talk about my COVID experiences from the perspective of healthcare epidemiology and infection control. But I do think there are very generalizable lessons for patient safety through that experience. And I'm going to try to do that through a number of different themes that you see outlined here. I'm going to begin by talking about measurement, because I think when we talk about safety and quality in healthcare, measurement is often one of the first things we talk about. We recognize that it's kind of fundamentally central to what we do. And I like to think about measurement as a spectrum. That's this one, right? There's that one side of the spectrum where we talk about that an impact that cannot be measured is not the same as an impact that does not exist. And I think that is important. There are some things that we struggle to measure, yet we know they're important. And on the other side of that spectrum is the reality, and very much the focus for us when we talk about patient safety. What gets measured gets done. Measurement is central to our efforts to improve patient safety. And measurement for COVID in healthcare was recognized as being central and critical to the response right from the beginning. Healthcare facilities, especially acute care facilities, are sentinel places, right? That's where people go when they are sick. So they are disease sentinels for their surrounding areas. They're likely to see something emerging before anybody else will. So knowing the case status in healthcare facilities is very important, but it's also critical to directing resources where they're needed most, right? The healthcare facilities that are experiencing the highest burden of infections need more personal protective equipment. They need therapeutics. They may struggle with staffing. And the more granular that information is, the more useful it is. Having information rolled up at a state or national level is not very helpful when it comes to trying to direct resources to the places that actually need them. And so what you've seen in the COVID data is this attempt to get to an actionable level of granularity with the COVID data. And that is, of course, what we collect data for, right? Data is collected for action, not just for counting. And so you see, at the county level here, COVID hospital admissions and the change in the last 7 days. Again, trying to get at a unit of measurement that could be actionable for local officials, for federal officials. Looking at the trends in hospitalizations, and this is data that's information available on the COVIDnet website, and I'm sure many of you have looked at this at the national and state level. We're also using some of that data to try and forecast, right? Because it's not just important to know what's happening now, it's important to know what we predict might happen in the future. And so there have been a lot of efforts, and you can see all of these different groups that are engaged in modeling efforts to try and help us understand what is going to happen with hospitalizations in the coming weeks. And there's a very nice hospitalization forecast on the CDC website. We're also, of course, looking at supplies of personal protective equipment. And here I'll show you some of the data from nursing homes. And again, hopefully many of you have seen this information. It is all publicly available, but we've been asking nursing homes on a regular basis, do you have enough personal protective equipment? Do you have enough for today? And what do you anticipate in terms of your supplies with respect to supplies being available for the next week? We have been tracking the skilled nursing facilities in the United States that have cases and PPE shortages, right? To try to find that overlap of the facilities that need assistance most acutely. If you're having cases and you have a PPE shortage, you have a compounded problem, and we need to get help to you as quickly as possible. So again, trying to look at this at the individual home level to help state, local, and federal officials direct those resources where they are needed most. We look at testing. Testing is obviously incredibly important for our efforts to respond to COVID, particularly in nursing homes, where we see that in these congregate living settings, there's oftentimes a quick transmission of COVID, some of which may be asymptomatic when it initially starts. And so we need to do a lot of testing. So we're asking nursing homes, do you have enough supplies to test everybody in the nursing home in the next week? And you can see here, pretty good, but there are 1%, 162 facilities who this week, when I pulled this data, didn't have those resources in place. So again, actionable, someone needs to pick up the phone and check in with those 162 and find out what they might need. Again, staffing shortages, another critical issue across the spectrum of healthcare, especially so in nursing homes, where we know they have been challenged by staff shortages even before the pandemic, and those problems have been exacerbated during the pandemic. We ask questions about whether or not they're experiencing staff shortages in the various professional categories, again, in an effort to try and direct resources to the places that need them most. What we've learned during COVID, though, and I think we knew this from the beginning, but COVID has certainly highlighted this experience, is that it's not just about what you measure, it's about how you measure it. Measurement in healthcare is complicated, even for things that seem simple. We've been having discussions, and there are a lot of people who have come to help help us in healthcare who don't have healthcare backgrounds. And so, we were having this discussion one day with some people who specialize in logistics, and they said, well, this seems pretty simple, right? Do you have enough N95 masks? That seems like a very straightforward and simple question. But when you're dealing with healthcare, even a question that at face value seems very simple becomes complicated very, very quickly. For example, what if we have lots of small masks, but most of our staff wear mediums? Then we don't have enough, even though we have a lot on paper. What if we can get supplies for masks that our staff's not fit tested on? So we have them, but maybe they can't use them properly. What if we're getting by using contingency measures like extended use and reuse? Does that mean we have enough? We're getting by, but we're having to do things that we wouldn't normally do. So should we actually report that we have a shortage? And then what if we have enough for right now, but cases are going up in our surrounding area and we think there's going to be a surge, so we don't think we have enough moving forward. So a lot of complexities to even relatively simple questions. The other aspect, of course, is that in healthcare, measurement is really time consuming, right? So do you have enough N95 masks? Again, going back to that relatively, quote, simple question. But if to answer that question, someone in your healthcare facility has to figure out, it's not just a matter of saying, oh, yes, we have 52 boxes of masks. It's, well, how many are we using each day? What does that trend look like? Or are those numbers going up or down? Then you have to know, well, how many do we currently have on hand and how many are en route to us? Because all of that factors in to the answer to this simple question, do you have enough N95 masks? So what that means is that when you're thinking about measurement in healthcare, you have to have a system that really is tailored to the needs of healthcare, a system that's designed to collect data from the healthcare sector. You need to have experts in measurement. The measures have to be developed carefully and thoughtfully by people who have experience in healthcare delivery. Because whenever you think about what you need to know from healthcare, there are a lot of questions that you have to ask. For example, are we going to get information that we ask on? When we ask these questions, there is a burden on the facilities who have to give us that information. So if we get information and we can't take action on us, then why are we wasting people's time getting it? How are we going to ask it? When we put these questions out, there are thousands and thousands of people who are going to look at that question and they have to answer that question. All of those people have to interpret that question exactly the same way in order for us to get useful information. And for us to answer the question that we're asking, they have to interpret it the way that we intended the question to be. So a lot of complexities with the wording of how you ask the question, which speaks to the need for having experts really involved here. And then there's the issue of how often do you ask the question? Every time you ask people to report, it's a burden on people who are already incredibly busy. And at the same time, we know the healthcare situation is very dynamic. So monthly reporting, even though the burden would be very low, would be completely useless. So it's trying to find out what's the sweet spot of that reporting. And again, bringing in a host of voices who can advise on how we do this thoughtfully and properly. At the CDC, we do have a system that is specifically designed for healthcare monitoring, the National Healthcare Safety Network. As most of you are probably very familiar with NHSN, it is the system that we use to track healthcare associated infections for the country normally. So it's the system that's already in place. Pre-pandemic was in place in every hospital, every dialysis facility, every ambulatory surgical center, and several thousand nursing homes. And then during the pandemic, we very quickly added reporting options to NHSN for reporting of COVID-19 data. And this obviously was, we thought, important. And it made a lot of sense to us because here is a system that meets all of those criteria that I've mentioned. It's designed for collecting data from healthcare. It's staffed by people who work on healthcare delivery systems all the time. And you have a lot of connections to people outside the government who advise us on healthcare measurement. The system has been in place for decades and does have an established track record. And one of the things that's really important about NHSN is that there's a careful process for vetting measurement items, including getting input from experts outside of CDC. So people who are on the front lines who can look at a question and say, I know you guys think that you're going to get the right information from that question, but in reality, that question's not worded very well. It's confusing to us. So I don't know. We would suggest that you ask it this other way. It's also a system that people were very familiar with, right? People have been using NHSN for years and years and years. So there's a comfort level and a familiarity. And I think it is really important to emphasize that we can never undervalue the importance of familiarity in what we do and how familiarity can actually improve quality. And, I think one of the great examples that I like to cite when we're talking about the importance of familiarity comes from this book by Derek Thompson called Hitmakers. And he's done a number of analysis. It's a really fun, quick read on what are the things that make items successful. And he doesn't actually focus on healthcare. He's talking about things like music and technology. But one of the things he emphasizes is that familiarity actually trumps innovation. Even though we think that we want things that are new and innovative, in reality, we will always, as human beings, gravitate towards things that are familiar to us. And there's a comfort level that comes with that can be really important. And I think one of the great examples of our desire for familiarity is with movies, right? If you look at the top grossing films of the 2010s, look at this list here. Bolded are all of the movies that were sequels, things that are familiar to us. We know the characters. So it just speaks to our human nature that we tend to go for what's familiar. And I think that's true and relevant in healthcare measurement, and also relevant when you're talking about a pandemic. So at a time when things are unfamiliar, having a measurement system that is familiar, I think improves measurement quality and lessens the load, lightens the load on our healthcare facilities. The last thing that I'll say about measurement is that almost all of the COVID reporting that is being done right now by our healthcare facilities is being done manually. And that is the reality of where healthcare measurement is. We have talked for a long time about the move towards more electronic measurement. We do have tremendous growth in electronic health records that will facilitate that type of measurement. But right now, most of it is manual. I think we're making progress with automatic data capture. And there's a lot of excitement about things like data automation and electronic case reporting that really will take us to this next level where nobody has to actually enter the data. The data gets pulled right out of the clinical record. So the same information that the clinicians are using can then populate the report. And so someday we will get to the point where most of this reporting, or even all of this reporting, is electronically, but there's a long road ahead to get there. The next theme that I'd like to talk about is the adaptation in healthcare. And I think there was a conventional wisdom pre-COVID that the healthcare system and healthcare providers are incapable of moving quickly, right? We hear all the time that, oh, it takes a decade from something to get from a clinical trial into common practice. And there is truth to that, right? There is inertia in healthcare. However, I think what we have demonstrated during the COVID pandemic is that there is also agility in the healthcare system. We can adapt very quickly. Within weeks of us standing up the hospital COVID reporting module, 60% of hospitals were reporting that information every single day. I mentioned that pre-COVID, there were about 3,000 facilities, nursing homes that were enrolled in NHSN and had been reporting data. Within a matter of weeks, we had 17,000 nursing homes, every nursing home in the country enrolled in NHSN and reporting data on a weekly basis. So healthcare facilities moved fast and adapted quickly. And it's not just for reporting, right? It's true clinically as well. This is looking at the change in telemedicine visits during the pandemic. And as you can see, there was this incredibly rapid uptick in telemedicine visits. So even though for many years, telemedicine visits, as shown in the light blue bars, had been relatively stable, when the pandemic hit and the public health emergency was declared, healthcare facilities very quickly adapted and found a way to make telemedicine happen, even facilities and practitioners who had not been doing it before. So a very quick and very agile adaptation to the pandemic. And COVID care has changed so quickly and dramatically during the course of the pandemic. We are looking at data from studies that are not even being published, right? Journals are doing a fantastic job of putting things out very quickly, some of it even before peer review. New practices are being presented. So this is evolving so fast. This is literally that example of your flying the plane as you're trying to build it. Remdesivir, dexamethasone, anticoagulants, other new therapeutics like tocilizumab. The way we have used these has changed and evolved so dramatically. And as providers, all of you have kept up with this information and you have adapted your practices. You brought things into place. And then when there was more data suggesting that you didn't need them, that practice was removed and changed. And we've seen that with antibiotic use, right? So this is hospital use of ceftriaxone, which rose very quickly during the early part of the pandemic when people were uncertain about what was going on with some of these patients. Lots of patients presenting to the hospital with febrile respiratory illness. But then you see in May, that use begins to drift back down to baseline, right? So as providers, as we became more comfortable with, we don't really need to treat patients with COVID for community-acquired pneumonia. These patients have COVID. They don't have community-acquired pneumonia. That use of ceftriaxone goes back down. The same for azithromycin, where use really spiked early on. And there was, some early indication or some suggestion that, well, maybe azithromycin has some antiviral properties and maybe we should use it for patients with COVID. And very quickly in March and April, became clear that that was not the case. Azithromycin was not helpful in the treatment of patients with COVID. And then you can see here, dramatically, use after going up by 30% falls immediately back to baseline or even below in May, as providers again learned that azithromycin was not helpful in these situations. And it's not just in hospitals, right? Here's this same data from nursing homes, where again, this big spike in azithromycin use with the thought that maybe it's either it could be prophylactic against COVID infection or therapeutic for COVID-19. And then it goes right back down as people begin to realize that, no, this isn't the right use for azithromycin, not indicated and not helpful here. So the providers and systems learned and adapted very, very quickly to new information. But when we think about information, I like this quote from John Johann Wolfgang von Goethe. It says, knowing is not enough, we must apply. Willing is not enough, we must do. So data clearly drives our doing, but we also have to be transparent with that information. And I think that is also something that's been very important. Again, a lesson learned a long time ago and emphasized during COVID. Transparency holds us all accountable and helps drive change. And a wonderful example of that is, of course, the nursing home data. The data is entered into CDC's National Healthcare Safety Network. CDC and CMS work incredibly closely together on infections in nursing homes, and that data goes from CDC over to CMS, and CMS posts that data publicly on their Nursing Home Compare website. And so you can go into cms.gov, into Nursing Home Compare, and see all of the information at the individual facility level. So as it's reported into CDC, it goes over to CMS and then is posted publicly. So there's full transparency about the data. But transparency, of course, comes with challenges. And all of you who work in quality improvement and patient safety know this. That fundamental question of, well, how level is the playing field? And in the nursing home community, we know that some nursing homes are very well resourced, and they're caring for patients who might not have a lot of comorbid conditions. They have independent means, so they have access to exceptional medical care. So their chronic conditions are very, very well managed. We also have nursing homes, we know, that have very, very limited resources, who are caring for residents with a number of chronic conditions who might not have access to all of the care that they need. So those conditions are not well managed. So is it fair, quote unquote, to compare the outcomes in two nursing homes that might look very, very different in terms of the residents and the resources? Which speaks to, how much control do nursing homes have over the COVID outcomes within their walls if the outcomes are driven by the comorbid conditions of the patients who are residing there. And that leads to this debate about the nature versus nurture debate applied to COVID in nursing homes, right? There's one school of thought, which is you should nurture, right? Through testing and infection control interventions and education and training, nursing homes can limit the entry and spread of COVID. So we should focus on those types of interventions. And then there's this nature issue where they said, look, nursing homes exist in a community. So really, it's what's going on outside the nursing home that's going to determine what happens inside the nursing home. The staff members have to come in. The residents themselves may have to go for appointments and then comes back. So we really can't decouple what's going on in the community from what's going on in the nursing home. And the question, it's gone back and forth, which of these is important or more important and more relevant? And I think the answer is yes, it's both. Nature and nurture. Nursing homes are dependent on what's going on in the community outside, and they have influence about what happens within the walls of the home. And we know a lot of this because there's so much testing that is going on in nursing homes. CMS does require that nursing homes do testing routinely of all staff members. And it's based on the percent of COVID tests that are positive in the community surrounding the nursing home. So as you can see here in counties where the more than 10% of tests are positive, they're actually testing those staff members twice a week on arrival to the nursing home. And it then gets less frequent as the percent of COVID tests decline. So we have a lot of information about testing of residents and staff in nursing homes. And what that allows us to do is to look at the trends in community cases and compare those to the trends in residents and staff in nursing homes. And all three of those data points are shown here, right? Where the black lines show you the community rates of COVID, and the red lines, the solid line is resident rates, and the dashed red line or kind of purple line are the staff rates for long-term care. And what you can see is that these curves overlap, right? They're almost identical, which indicates that when there are surges in the community prevalence, we are going to see surges in both staff and residents in nursing homes. And when that community prevalence goes back down, that trend is then reflected in the nursing homes. It speaks to the speed with which COVID data changes. Very intriguingly, these lines are now really beginning to diverge. They began to diverge sometime in December, actually just before the vaccines actually came out. So we are now kind of exploring what led to that divergence between the nursing homes and the communities. We think vaccines may be playing some role in that. And there's, of course, a lot of evidence that it was also due to the hard work that nursing homes have been doing with infection control, because these trends, as I mentioned, did diverge before vaccines were widely rolled out. But it really speaks to the point of how dependent nursing home rates are on what's going on in the surrounding community. Well, what does that all mean? Well, we have to continue to encourage nursing homes to measure what matters. We encourage transparency with that data, and of course, data is for action. We should use that data to drive improvements. We also need to ensure that nursing homes have access to the resources that they need, right? They need testing, they need PPE, they need staffing, all of which have been ongoing challenges, especially early on in the pandemic. And then they need the expertise. They need that quality improvement expertise so that they can impact those outcomes. We also need to make sure that everybody knows that what happens in the community has a profound impact on our most vulnerable citizens, the people who are residing in nursing homes. I'm going to shift gears a little bit and talk about some of the issues and challenges with healthcare delivery and patient safety during COVID. And again, I will do that through my lens of healthcare epidemiology and infection control. And this is just one example of some of the challenges that we've seen. This was an outbreak that was described and published in the MMWR, an increase in hospital-acquired multi-drug-resistant infections, carbapenem-resistant Acinetobacter baumannii. And what you can see is that this was a hospital that reported a cluster of cases of this very, very difficult to treat organism, and it peaked during a surge in COVID-19 hospitalizations. And what they felt is that, the strategy to preserve continuity of care led to deviations in infection control practices, right? The attempt to deliver safe care, but challenges with how personal protective equipment was used, isolation precautions, led to challenges with infection control. And once the COVID began to go back down and they were able to resume more normal operations, this outbreak went away. And there have been a number of these reports of outbreaks of multi-drug resistant organisms during COVID, especially on COVID units. It's not just limited, though, to these drug-resistant infections. Hospitals around the country have been reporting increases in central line-associated bloodstream infections in 2020. And we're hearing similar reports from other countries, right? So it's not just here in the United States. We think this is multifactorial, right? There's a strain on healthcare personnel that makes it very difficult to follow infection control practices perfectly when you're also having to deal with the added complexity of managing patients with additional personal protective equipment with all sorts of new protocols and procedures in place. We very appropriately had a lot of efforts to reduce room entries, right? We were really trying to limit the number of staff members who might be exposed to patients with COVID. But what that meant in many places is that the line teams who had traditionally done all of the care of central lines, dressing changes, drawing blood samples, might have been limited in what they were able to do to reduce room entry. So they weren't caring for central lines. And we know that acuity goes up in many of these COVID surges. There are a larger number of patients who end up in intensive care units. And those, of course, are the patients who are at the highest risk for these central line associated bloodstream infections. So a confluence of circumstances creating that perfect storm for an increase in central line associated bloodstream infections. And I think what that means to us from the patient safety perspective is, again, it highlights many of the things that we already knew, right? Our infection control systems are not designed to work well under stress. And I would argue that there are very few systems that are. So I don't think it's in any way a condemnation of our infection control systems. It's a recognition that there is this significant limitation that's in place. But these implications are literally life and death. When we're thinking about COVID, it's not a win if we save someone from COVID, but they end up succumbing to a healthcare associated infection. And, I wish I had the easy solution. There is no easy solution to this challenge. It emphasizes to us how dependent our current infection control practices on human behavior. Infection control is a very manual operation. It depends on people doing the right thing time after time after time. When you talk to experts in system design, they will tell you that is the system that is most vulnerable to failure. Any system that requires someone to remember to do things and then do them consistently is the system that is most vulnerable. So it leads to this thought of, well, are there ways that we can fundamentally redesign infection control systems to make them less dependent on people having to remember and apply a complex series of steps over and over again. If this were easy, it would have been done. But I think COVID has really lent even more urgency to thinking about new ways to approach infection control to try and build better systems. We are also, I think, learning that our infection control branch is far too narrow. During COVID, of course, infection control staff shifted their attention to COVID, fully to COVID, right? Because that was the pressing need. But that left other important functions, I would call it uncovered, right? It happened in antibiotic stewardship as well. Infectious disease pharmacists, who are often the stewardship leaders in our hospitals and other facilities, had to shift their focus very appropriately to managing COVID therapeutics. And again, many of them had to leave their stewardship activities aside, shift over to COVID. Very appropriate, but what that means is that it leaves the stewardship work uncovered. There's no one to do that anymore. Especially a challenge in nursing homes where oftentimes you don't even have a person focused full-time on infection control. The person who does infection control in nursing homes is often wearing multiple other hats. They're the quality improvement person. They do occupational health. So when they shift over to COVID, even more activities are not covered. So I think this impacts infection control, especially in nursing homes. And I think those impacts, we know of some of them, and I think there are many that we haven't even begun to realize. This problem of the narrow bench in infection control also extends to the public health sector, right? We are lucky in the United States that every state now has in its health department a healthcare associated infection and antibiotic resistance program. And these programs are phenomenal. They do amazing work. And they have really stepped forward during the COVID crisis, especially for nursing homes. So those nursing homes that have limited infection control expertise and infrastructure have really relied on our state healthcare associated infection programs to provide them with that expertise that they need. But it's a limited resource, right? At best, you might have 2 or 3 people working on this, with most of that funding coming from the federal government. So the question is, how do 2 to 3 people in each state address the needs of the 15,500 nursing homes and the roughly 25 or 30,000 assisted living facilities? And the true answer is that they can't. There is no way for that small number of people to address this very, very large need. COVID has also, I think, demonstrated the important interdependence of the relationship between healthcare and public health. And I think some of these connections were obvious going into the pandemic, right? We really need to work collaboratively across healthcare and public health when we're talking about allocating limited resources like therapeutics and personal protective equipment. But I think some of these connections were new during COVID and have really paid dividends. For example, the support that the healthcare associated infection prevention programs at the state level have provided to nursing homes. This was something relatively new and was a wonderful resource and has been a really, really powerful and helpful for us. Also, a lot of healthcare facilities took on contact tracing efforts, especially for their staff. As our health departments were overwhelmed with trying to do contact tracing in the community, we saw so many examples where healthcare facilities stepped forward and said, hey, you know what? We see that you're overwhelmed. We can help you. We can do some of this contact tracing for our staff. It's beneficial for us and helpful to you. And that great partnership was formed. So the importance of that public health healthcare challenge. And I think when you look back on this, what we are learning, of course, is that everything old is new again, right? All of these challenges that I've described, these lessons learned, were not new. These are things we've known for quite some time, but the experience of the pandemic has really laid them bare. It's magnified them on an unprecedented scale. Some of the problems that we knew before were amplified. Some of the solutions that we put in place began to fail because they were simply overwhelmed. And I think that was especially true in long-term care. It's really interesting if you look back at long-term care. This was a paper from 2017. And if you look at this challenges, right, the challenges include a paucity of evidence, limited staff resources in nursing homes, insufficient infection prevention education in nursing homes, and a perception that isolation and contact precautions negatively influence the well-being of their residents. So all of these, you could take out multi-drug resistant organisms and swap out COVID for that title, and you have exactly the same types of challenges that we encountered during the pandemic. These are big problems, and I believe that they are going to require bold solutions. We can't just slightly modify the systems that are in place now and expect them to work well under these extraordinary circumstances. We need to fundamentally rethink the way we approach infection and prevention and control in long-term care. It's not going to be easy, and when you have a big problem like this, you need to draw on a huge base of expertise. And in fact, there has been a group of experts, a commission, that was designated by CMS, the Coronavirus Commission on Safety and Quality in Nursing Homes, that brought together a number of experts, external stakeholders from all across the spectrum, right? It was providers, professional organizations, resident and family advocates, as well as researchers and academicians to think about how we can address these problems and come up with bold solutions moving forward. And I think fundamentally, we can't simply go with the flow anymore. This is a great cartoon from the New Yorker here where it says, my motto was go with the flow, but I had no idea the flow would end up here. We have to buck the trend. We have to do things that are new and different. And we have to be open to all sorts of different options, right? And it is, I think, likely that part of the solution, part of this path forward is going to be a call for new regulations. We've already seen that come forward from some of these expert panels that have weighed in on what might be needed. And I do think we have to acknowledge, though, that the idea of regulations leading to improvements is often controversial and often does get pushback. As someone who is often in the position of weighing in and writing regulations, we often hear things like, healthcare is already over-regulated. We're more regulated than most other industries. And, one of the challenges and a legitimate issue is are regulations going to stifle innovation? We need innovation in healthcare, but if you regulate an industry, are you going to stifle that innovation? And I think we can turn to other sectors to understand that regulations don't always stifle innovation. And in fact, there are some really intriguing examples of situations where regulations have motivated and led to innovations. And one great example that I like to cite is this one here. It was in the 1970s with environmental standards, when the Environmental Protection Agency issued new regulations to reduce car emissions. And the regulations that they introduced were actually not achievable with the current technology that was in automobiles at the time. And there was actually this wonderful Senate testimony where an engineer from Chrysler told the US Senate that if they passed these standards, it would mean the end of station wagons and large sedans in the United States. Well, any of you who have driven anywhere in the last few days or weeks know that that's certainly not the case in the United States, right? There are lots and lots of sedans and very big cars on the road that have very, very low emissions. So rather than abandon larger cars, car companies developed innovative solutions, catalytic converters, electronic fuel injectors that allowed them to meet these new standards through innovations. And they say that because of these innovations, there are about 500 current model vehicles emit what a single 1970s model did. So an example of regulations actually driving innovation. The other issue is, do regulations demotivate progress and lead to reduced expectations of professionalism and senses of respect for the profession? If you're heavily regulated, are you going to be viewed less favorably because you're just, pushing the buttons that you were told to push? And I think that, again, that's not necessarily the case. When you think about industries that are really safe, we all always, of course, look to the aviation industry as being one that's really had a model of safety and a commitment to continuous quality improvement. And that has not led to pilots being less respected by any stretch of the imagination. In fact, you could, in this poll in 2015, even though the airline industry is incredibly heavily regulated, people don't view pilots as, oh, you're just pushing the buttons you were told to push. They're a very, very highly respected profession. And just an example, when we think about industries that are regulated, there is actually, believe it or not, an index for industry regulations. And it's shown here only to make the point that healthcare doesn't even appear on the list of the most regulated industries. So it's not the case where we are regulated more than some of these other industries where they have found ways to innovate and found ways to have very, very highly respected professionals in them. And I will certainly be the first to say that you cannot regulate your way out of the current challenges with infection prevention, especially in long-term care. I think that regulations can be an important part of what has to be a much larger solution. And so there are a number of ideas that are being proposed and are being talked about. For example, regulations to enhance infection control infrastructure and training. Could we make the programs, infection prevention programs in long-term care, look more like those in hospitals? There are regulations to, again, being talked about to increase the surveillance and reporting of healthcare-associated infections in long-term care. Would that give us better insights into what's going on and help us understand the challenges that need to be addressed? So in summary, I think there are a number of very important lessons learned about patient safety that can be viewed through this lens of COVID, especially in the issue of healthcare infection prevention and control. Measurement will be central to our progress. We have to think, though, both about what we measure and the systems that we use to measure it. Transparency is important in measurement, but we have to acknowledge the challenges that transparency poses and take steps to address those. Contrary to popular belief, I would argue that healthcare, we can adapt, learn quickly, and be agile. Infection control challenges are interdependent, so focusing on something new can come at the cost of progress that we've made in other areas, and we have to remember that. Our infection control bench, both in healthcare and in public health, is too narrow, and the important connection between healthcare and public health, as we've seen in infection control, both of us are better together. And we have to think about new approaches to care delivery, new approaches to infection control. If we are going to make transformative progress in the post-COVID world, it's going to come from innovative and transformative solutions. And above all, I think we really have to remember at every stage of doing this is that success is going to be collaborative. No group is going to solve all of these problems on its own. It's going to take all of us working together, and leaving any group out of the solution is only going to weaken the solution that comes. So I think we all have to approach this from a framework of humility. We have to listen with an open mind and recognize that none of us holds all of the solutions. So we have to listen to all of the ideas that are coming forward, and we have to admit when we get it wrong. We're not going to get everything right when we do it. And when that happens, we have to say, you know what, we did that wrong and we need to change it. And I'll just close with this wonderful quote or table from Don Berwick's speech, all together or not at all, the Snuggle for existence. If you haven't seen the video of this talk, I can't recommend it highly enough. It's absolutely beautiful. But I think he emphasizes in healthcare that, more often in healthcare, or at least historically, we've been on the left side of this slide, the try harder, pay for performance, follow the rules, randomized trials, more of this, more of that. And he said, we need to shift our thinking to this other side. How do we understand and learn that we're all in it together? We have to have pride in what we do, use tests of change, modify things as needed. And at the end of the day, the reality that only a team is going to succeed to solve these problems. I'll close with that. I do think we have a few minutes for comments and questions. And again, I just really want to thank the team there at VHHA for giving me this opportunity to talk with you. Really enjoyed the time with you today. And again, I really do hope to see all of you in person someday soon. So let me turn it back over to the team and see if there are any comments or questions.
Thank you, Dr. Srinivasan. We do have a couple of questions in the Q&A. And if you don't mind, and we thank you very much for your presentation today and are really glad that we've had you with us. The first question in the box is there a method in place to validate the accuracy of nursing home data?
Yeah, that's a great question, right? The critical need to validate data that gets reported. There is some, the nursing homes obviously get surveyed, by CMS. And during COVID, there were a lot more surveys that were done. And there was during some of those survey processes, there was kind of a look back at, well, here's what you reported into NHSN. Let's look and make sure and confirm that in fact, that is the accurate information and to be reported. And that happened, I think, both in nursing homes. It also happened some in hospitals. And that type of validation, as you're pointing out, is really, really important. And again, we have to think about validation not as a punitive, oh, you were lying when you put that information in, but more often than not, what we learn during validation is that the question's not clear. And so validation is a really, really important step to improving the way that we ask the questions and improving that measurement system.
Thank you so much. Another question we have is, can you talk about the impact of COVID on other HAIs?
The data we have right now, we have the most data on CLABSIs, and we've seen an increase in central line associated bloodstream infections. We haven't seen as much change in reports of catheter-associated urinary tract infections. And we are also seeing some increase in methicillin-resistant Staph aureus infections. And some of that may be driven by the CLABSI issues. That's what we know right now. We are working very hard to analyze that data so that we can try to better understand globally what happened with healthcare-associated infections and, of course, antibiotic resistance during the COVID pandemic. It's really, really important work that is being done.
Thank you. Another question that we have is, what strategies do you suggest to alleviate stress and burnout amongst our nurses?
I wish I had the right answer for that. It has been such a challenge. It's a challenge at baseline, and during the pandemic, again, it's one of those challenges that has been truly laid bare. I think some of the things, first of all, recognizing and acknowledging that stress and burnout happen and are really important to address. I think that's the most important first step. Too often, I think, as healthcare providers, we don't recognize and acknowledge that, right? We're tough, we're taught to be tough, but we really have to recognize and we have to encourage people to raise their hands, to recognize the signs of stress and burnout, and then to be ready to raise your hand and say, you know what? I have some of these signs, I need a break. We have to figure out a way to put some flex into the system so that people can get scheduled breaks and time off so that they have a chance to recharge. We need enough flex in the system so that if someone very acutely develops that stress and that burnout, we have someone who can step in. We can give that person the time off that they need. And then, of course, changing sick leave policies, really making sure that people don't come to work when they're sick and there's no penalty for them not showing up when they're sick. So I think a lot of different strategies have been tried during COVID. I think we have made progress in acknowledging that stress and burnout occurs. I think we probably made a little bit of progress addressing it, but I think there's a lot more that we need to do in that area. It's a really important issue.
Thank you. Another question, is there a plan for COVID risk adjustments at the national level in the NISN data for HAI outcomes?
Yeah, that is something that we are definitely talking about, and I think it is really important. So that is part of the information that we're looking at when we're looking at the healthcare associated infections, is also trying to figure out, what's the impact of COVID, and is there a way to try and adjust for COVID burden when you're looking at healthcare associated infections?
Thank you. We've seen an increase in hospital-acquired pressure ulcers. Is this common across the country?
Yeah, we don't have, at least I have not seen as much data on pressure ulcers. I can't imagine that it's not the case. I mean, it only seems like we would, given especially the fact that we just don't go into the rooms as often. We tell people, avoid going into the rooms if you can avoid it. So I would not be at all surprised to see that is the case. And again, how you mitigate that, I think we've got to bring experts to the table to help us understand, are there ways that we can combine the safety of our healthcare workers and not have them be exposed, and meet the needs of residents and our patients not to have adverse outcomes like pressure ulcers.
Thank you.
So I think we can get to one final question, and it's, so what advice do you have for senior hospital leaders as to how we approach epidemics, flu, et cetera, in the future? Will the CDC recommend masking in the future during epidemics? We have seen no documented flu cases locally as a result.
Yeah, Abraham, thank you. I think that there are going to be chapters and chapters and books written about what we do next time based on the experiences that we've had this time around. And I think I see kind of two parts to that question. One is, I think, the easier one with the masking. I think, yes, I think we've seen that the masking as a source control measure has been incredibly effective. And I think we're even learning that those masks that we initially thought, my mask protects you, your mask protects me, there's a growing body of evidence that suggests, well, actually, even the cloth masks and the procedure masks, they actually might protect me to a certain extent too. So I think much more to come with the mask story. Same story here in Georgia. We've had an almost non-existent influenza season so far. Knock on my wooden desk here. And I think there's a lot of thought that that's related to the masking and distancing. So I think that is something that we've learned a lot about during the pandemic. The other, I think, more important part of that question maybe is what can healthcare leaders do? And I think the most important thing that leadership in healthcare can do is send that message that quality and safety are central to everything that we do. It has to be baked into the culture. It can't be we provide medical care and that quality and safety thing, yeah, it's an addition to what we do, but it's not the center of what we do. And I think, again, this is preaching to the choir here for the 700 folks who are on this call, because you wouldn't be on this call if you didn't think that patient safety and quality were fundamental to everything you do. You wouldn't take an hour out of your 20-hour workday probably to come to this to this talk if you didn't believe that. But I really would love to learn more from healthcare leaders on how we can impart that view of quality and safety to all leaders in healthcare. And I think that is, to me, what healthcare leadership can really do, is to try to figure out, how do we translate that experience? How do we get every leader in healthcare into that same frame of reference? Because I think right now we have some places where they're all in on quality and safeties, and others where they're not as much. And it is the tone and the message of the leader, which so often drives what we see in practice. So I would love to see how we make that universal across our healthcare continuum.
Excellent, excellent. Thank you so very much, Dr. Srinivasan.
Thank you.
As we prepare for our next presentation, I may impose upon you to see if you might be able to look into our question box and respond to, I think, a couple of remaining questions there. And for our attendees, we're going to now share with you some additional comments from members of the Virginia General Assembly as we transition to our next presentation. Thank you all.
Hi, Delegate Hala Ayala here, and I just want to say thank you to all who are joining today's 2021 Virginia Patient Safety Summit. I actually govern in Prince William County, and my districts cover Manassas, Prince William, and Lake Ridge. And as you know, we have a generous healthcare system. I just wanted to spend a couple minutes today and just say thank you to everyone, not only who are attending this summit, but who are promoting safe healthcare practices across the Commonwealth. Your work is so very meaningful to making sure Virginians have access to the highest quality healthcare. COVID has brought on new meaning, new challenges, and new fronts for our frontline workers and our healthcare workers. You are all guardians, angels, and warriors who have stood in the forefront of this pandemic. So I want to say thank you for all of your meaningful, life-saving work that you've done for every constituent, every member, every individual of our Commonwealth. It's critical that we have you, and it's also critical that you take care of yourself as well, especially during this pandemic. We need you to stay healthy, and we need you to stay safe, both mentally, physically, and spiritually. So today I've dropped in just to say hello and thank you from the bottom of my heart. And thank you for all that you do for my community. And I hope that you have a wonderful time for all who are joining today's Healthcare Summit. Learn a lot. And again, thank you for your service. Be well, be blessed, and Happy New Year. Take care.
Hi, I'm Delegate Carrie Coiner, proudly representing the 62nd House District, representing Chesterfield County, the City of Hopewell, and portions of Prince George County. On behalf of my family, I would like to say a big thank you to all of our healthcare workers. I know you all have your own stresses and anxieties. You are giving up things in your own personal life and time with your family so that you can ensure the health and safety of citizens across the Commonwealth. Thank you for all the sacrifices you have made to ensure that our public can be cared for. I'd also like to thank you for publicly sharing your vaccine stories. You sharing your stories of receiving your vaccine really helps ensure that those in the public who are up next feel more confident about getting their own vaccine so that we can more quickly gather back together again in the future. Thank you for publicly putting yourselves out there on social media and sharing your stories.
I'm Delegate Glenn Davis. I represent the 84th District down here in Virginia Beach. And I just wanted to say thank you to all of you attending this year's Virginia Patient Safety Summit. Thank you for everything you do to provide quality, affordable health care to Virginians across the Commonwealth, and for all of you on the front lines right now during this COVID pandemic and making sure that people have access to the health care they need, and for putting your own lives out there on the front lines for all of us in Virginia. Thank you for everything. Please be safe as you continue helping Virginians across the Commonwealth, and thank you again for everything you do.
Hi, I'm Delegate Rodney Willett. The residents of the 73rd House District here in Western Central Henrico and I are endlessly grateful to the doctors, nurses, technicians, and all healthcare workers and healthcare system staff that have kept us safe during this pandemic. You have worked tirelessly throughout this crisis to keep patients safe. However, ensuring your safety and protecting the physical and mental health of Virginia healthcare workers is just as critical. Thank you for all that you do.